Yes, regarding the treatment of neuroendocrine tumors, what are the where we stand about the promising results with the MIBG or this neuropeptide?
You can use also MIBG scan for evaluating of these patients, but normally MIBG is better for medullary thyroid carcinoma or paraganglioma and also neuroblastoma, but for GAPNet tumors, normally they are negative. Sometimes the patients who show the very have functional tumors, they can show MIBG positive accumulation, but as I said, normally they are negative or just lightly positive.
Dr. Marha.
A short question from Dr. Eric. It was a wonderful presentation regarding radium-223 and some interesting cases. The one which you said was responding as far as the NAF was concerned, you did not show the PSA in that one. Is it going down in that one? So is there a concordance or?
So there's a lot we don't understand about radium-223 and how it works. I showed you the one case of the patient where the PSA had gone up and then gone back down. The second case I showed, they actually didn't follow the PSA during therapy, so we don't mandate the particular laboratory values that they follow during therapy apart from the blood counts, which are required as part of the treatment. So in that particular patient, we didn't have the PSA values to follow. Interestingly, the majority of patients do not have a PSA response. And so that's actually another thing I make sure to talk to them about up front, is the fact that as they get this therapy, their PSA may stay the same, it may continue to climb, but what they found in that phase 3 trial is that there was no difference in survival between the patients with elevated and progressing PSA versus those with a decreasing PSA. So in other words, there were patients that responded well to the therapy and were in that better overall survival group that had a rising PSA. And there were patients that had PSAs that stayed stable that ended up, expiring from their disease. And so I make sure to tell them, if we check your PSA, it may continue to rise during this therapy. And oftentimes they do have nodal disease and other sites of disease that were not being treated by the radium, so it's not surprising. But I say, don't let that worry you, because the patients are used to the fact that they go on a therapy, hormonal, chemotherapy, and they want to see their PSA decline afterwards. So they're used to using this as a judgment for the effectiveness of therapy. So I make sure to tell them, your PSA, is not going to tell us how well this therapy is working. We're more interested in how you're feeling and what the scans look like. So that's an excellent question, and it's something that takes a little bit of getting used to, that the response to radium and the PSA are a little bit disconnected. Sometimes we'll see a response, but not always.
Dr. Abdul.
I have a question about the radium. So suppose that people are starting to shift based on the fact that this agent is a kind of a novel with less side effects, less hemotoxicity. This would be applied, for example, in breast cancer. Would you think that the method of assessing the response would depend only on imaging modality, or most of the time it will depend on, for example, tumor marker? This is question one. Question two, do you feel in the future that this kind of treatment would decrease the use of strontium, samarium, and other bone palliative agents?
So two excellent questions. With regards to the first one, it's a tricky part about radium, and it's hard to sit down with a patient. Sometimes they'll ask me, how will I know if I'm responding to this? And we know what the curves look like, that as an aggregate, when you treat people with radium, they do better than those without treatment with radium. But with a patient sitting in front of you, you can't tell what group they're belonging to because you don't know what path they normally would have taken. So in some ways, the radium is just given for the 6 doses as long as they can tolerate it, based on the justification that you can improve overall survival in a large group of patients. But it's difficult on an individual basis to know what truly effect that therapy is having. Symptomatic is one thing. So the patients will feel better, they'll feel more energetic, and that's a positive outcome. If you do see a response of the tumor markers, that's obviously nice. We've looked at alkaline phosphatase, and it does seem like radium can decrease alkaline phosphatase during the therapy. Acid phosphatase is another that we've seen some declines with the initiation of radium therapy. So there may be some markers out there that may show us how well this is affecting the bone. We're also interested in looking at other imaging studies, not only sodium fluoride, which is showing us the bone reaction to the cancer, but perhaps FDG PET CT or choline, carbon-11 choline or fluorocholine PET CT, which may show us actually the metabolism or the function of the tumor cells within the bone, maybe as a better reflection. So if I were to do this in a patient with breast carcinoma, I would consider sodium fluoride, but I might even more strongly consider, say, FDG, where we know that many of these patients do have very FDG-avid disease in their skeleton as a marker for therapeutic response. And then you'd be in more solid ground in terms of conveying what that degree of response is. And then remind me of your second question. Oh, correct. I think we will see potentially a transition away from them. We never had a huge demand for samarium and strontium from our referring clinicians. They felt they could palliate the pain in other ways, and we saw a few patients coming through with very end-stage disease. Radium, they're much more engaged in because this is a therapy for the cancer, and actually the NCCN guidelines that are published in the U.S., the National Comprehensive Cancer Network, have put this as a Category 1 recommendation for men with bone disease from prostate carcinoma, right alongside docetaxel, which is the primary chemotherapy. Category 1 means that this is a recommended therapy based on prospective randomized data. We almost never get this in imaging, in radioisotope therapy, but they have strongly recommended the use of radium-223. We've still seen a few patients, though, that have gone on for samarium and strontium, so I don't think the answer is out yet, because what we've seen is I've gotten some requests for patients to be treated with radium, and then I sit down and look at their medical record and see that they've had liver disease or see that they have very poor performance status, that they're bedridden, and obviously they're at the end of their life. And rather than embark on a very expensive and invasive type radium protocol that's going to put a big burden on the healthcare system, if I talk to the clinician and say, if your objective is really just to make this patient feel better, and based on the extent of disease in this patient, it doesn't seem like radium is going to be an effective cure or effective treatment, we've actually transitioned those patients from radium onto samarium. So it's possible that as the program develops and we see patients that get referred in for radium, those that are not good candidates based on the burden of their disease, extraskeletal disease, etc., we may actually be directing them into samarium or strontium for palliation. And now that we have this pathway of communication, we have better communication with the referring clinicians, may be able to recommend those therapies more. So my guess is that a lot of patients that would have in the past gotten samarium and strontium will be treated with radium, but I think it will go the other direction, that patients that they're considering for radium may not be good candidates, and we can push them back into a palliation with either of those two agents.
One minute, you can take the mic.
The cost is a consideration.
So it's
Can you repeat the questions? We don't hear it. Can you repeat the questions?
I think you understand that. What is the cost? I remember strontium was very expensive when it was launched.
Yeah.
How expensive is radium now?
So the question is with regards to the cost of radium, and I will tell you that it's quite expensive. The figures are going to vary. So there are the U.S. figures. There will probably be European figures. I'm not sure what the local figures would be. But Bayer, who is the company that holds proprietary rights to radium-223, along with Algeta, which is the initial Scandinavian company that developed the agent, they kind of co-own it, priced this according to chemotherapy. So they looked at the market and determined what it would cost to treat a patient with 6 months worth of chemotherapy, and kind of used that as their benchmark. Keep in mind, too, that right now there's a sole reactor in the world that can produce the agents necessary to eventually make the columns and elute the radium-223. For the U.S. market, it's produced in Scandinavia, Norway. It's then flown in bulk to Denver, Colorado, where the central production facility is. They draw out the patient doses in Colorado and ship them on an individual patient basis all over the country. And so what we're waiting for is a huge snowstorm to shut down Denver, Colorado, and potentially have a big impact on the distribution of radium throughout the country. But it's a very labor-intensive process, and they had to put years into the development of this process. So on the one hand, radium-223 is an element. It's a salt, so there's not chemistry involved or anything else. But on the other hand, there was a developmental process. There is a big production facility that goes all the way from nuclear reactor to GMP-grade material that can be injected into patients. And then this is basically competing with some very expensive chemotherapies. And so the values, the cost of a 6-dose course of radium is above 6 figures, US dollars.
Any more questions? I want to ask one question regarding the distribution of radium. Is it comparable to the distribution of NAV, so you can depend on NAV to assess the distributions of radium, or you are depending on the clinical response of NAV after treatment?
So the question is can we assume that the distribution of radium is the same as sodium fluoride PET-CT, or do we mainly rely on symptomatic improvement? It does seem, based on some limited studies, including that osteosarcoma case I showed, that the areas that light up on a bone scan are indeed the areas where the radium is localizing. And it would make sense that being a alkaline earth element, it's going to go where calcium goes, so it's going to localize to those areas of the bone where there's metastatic disease with increased activity on bone scanning. So we do assume that the areas of uptake on bone scanning are the areas where we're going to see radium localization. But the radium images are not very good, and nobody's ever done a study showing that definitely connects. For example, with samarium therapy, we can do dosimetry because it has been shown with samarium that MDP and samarium localize in a very similar fashion. So we can use samarium images to perform dosimetry with planned high-dose samarium therapy for patients with osseous metastatic disease. The same has not been done with radium. So there's no final answer to your question, but we do assume that it's similar. Another support is an interesting phenomenon that I've seen in a few cases where patients have bone disease at baseline. We treat them with radium. The lesions that were very hot and very big at baseline have decreased in intensity in the interim. A lesion that was quite low in intensity and small at baseline may have actually increased in size and intensity. So perhaps the radium is going very strongly to those big hot lesions at the beginning. The lesions that showed relatively little activity at baseline don't get much radium during that initial treatment cycle, and then we need to catch up and continue the radium therapy. At the end of the day, though, this is basically administered as long as the patient can tolerate it. So when you embark on the initiation of therapy, your intention is to get them through all 6 doses of radium unless something arises that they need to switch therapy or can't tolerate the therapy. So we're using the sodium fluoride at the interim time period to learn more about how this is taking place, and we actually do discover patients with progressive lung disease and liver disease that get switched onto chemotherapy with that sodium fluoride. But its intent is not necessarily to tell us what's happening with the bone disease. I think that's an unanswered question at this point that we need more experience with. So the intention would be to get them through all 6 treatments unless something happens that would force them to come off.